The trouble with Pathoma is I don't think Robbins is right for a medical student. Testing teaches pathophys. Do you have a mental picture? Go take a look at Robbins and see how many of those are there. The answer is none. It's for a first-year pathology resident. Do you really think you should know 12 testicular tumors? No, that will harm you because you'll actually think you should know that. How many ovarian neoplasms do you think you need? I teach 4. There must be 44. Don't do that. What do we like in my book? The first is those pictures. Those aren't illustrations. Those are my brain. And my brain isn't special. All doctors see it this way. I'm just showing you how medicine teaches itself.
We have an existing community, if you guys are aware, mscmeded.com. It's got a ton of content, videos, question bank, all that kind of good stuff. All of that is going to be transferred over to the new community where you will also be going live and doing lectures. Because that's the other question. A lot of people are asking, where are you teaching? They want access to you. So what are your thoughts on what we have coming up here?
Well, I'm very gratified. All I can tell you, and it's going to sound like braggadocio, but it's just not. This works. You're absolutely right. When you say, finally, this makes sense. This is what I always thought medical school would be. I can only tell you, so did I. I went to medical school and I went, why are these people so unpleasant? Why am I memorizing these things that clearly don't matter? And so when it came time for me to teach, I hadn't forgotten. And what you're seeing is, I mean this in the nicest way, it's the way I wish I'd gone to medical school. But here's why you can take it as gospel. Because I practiced for decades. I practiced in small hospitals as a general pathologist. I touched every doctor. A week didn't go by, an ER doctor didn't come and say, we need faster results. To which I would always say, explain to me pre-analytic, analytic, post-analytic. Meaning pre, from the time the patient walks in the door to you think, I need a hemoglobin. Analytic, you order from the lab, we draw the blood, we give you the result. Post-analytic, from the time that answer hits the ER till the doctor acts. Yeah, it turns out it was an hour pre-analytic, 18 minutes of the lab, and another hour before anyone acted. And I went, great, let's cut my time in half. That's 9 minutes. Are you kidding me? So every aspect of medicine I've thought about. I've been directing surgery in the OR. OB wants to create a hotel experience for delivery because women spend the healthcare dollars. There's no aspect of healthcare at the general level that I haven't touched, especially because I've lived through so many revolutions. We've talked about how I started at a time of autopsies, and they just stopped being useful after you get really good CT scans and MRI, and the lab testing in an 80-bed hospital is as good as a university hospital. It's just a revolution. We had to teach ourselves fine needle aspirate cytology because there was no way to put a needle in to the chest or the abdomen before CT scans. So not only have I touched widely across medicine, but I've lived through all these revolutions, so I truly understand change. And so I can tell you, this is what you need when you go to clerkship and residency. And all this stuff is so new. I'm not kidding when I tell you this. Sometimes when I have to give a lecture, I go back to the book and I go, wow, that's really good. Because I haven't looked at it 8 or 9 months ago. God, that's actually, wow, who is that guy? I really like that stuff. So you're going to be able to take this to your practice. Great. I know you're going to ask it, so I'm just going to tell you right now. What about the national exams? And the answer is, the national exams are this. Why did you learn it? Clinical medicine is built on a foundation of basic medical sciences. So when you're studying to be a good doctor, you're doing exactly what you need for your national exams. So people aren't right in their sense that this feels right. I can promise you, I've taken students, I've spent so much time teaching in the Caribbean. And it's really interesting because these, as a general rule, are students that are poor at taking exams. And you can't believe how little that has to do with whether you're going to be a good doctor, whether you respond well in crisis, do you keep up with new things, can I trust you to do a good pass-off? All the good things that make you a good doctor really don't relate very well to how you do in multiple choice questions. But if you can't do it, that's how we do the admissions and failures. And so when you've taught in the Caribbean, you've taught students who are poor at exams. Nothing to do with clinical practice. And I can promise you, they all get through step 1 and step 2 when they do this. So you can be dyslectic. I mean, the tough one's panic disorder. Okay, if you've got panic disorder, that's really hard to deal with. All I'm saying is, but the best way to deal with it is to have a plan. And I've had lots of students that have panic disorder, by which it means you underperform in exams relative to what you know. That's always a good sign of panic disorder. And here's what I'm telling you. Take a breath. There is a plan. Find the chief complaint. What's the differential? Look for the pathophys. That will always be true because that's medicine. So as excited as your students are, it's going to get way better yet. And yes, it really works.
So there's a textbook element to this whole conversation, which 2.0, do we have a new update on?
Every day I get promised it's days away. So I don't know what to tell you. They've promised them many times.
A lot of people are asking, they recently bought version 1.0, and they're asking, what's the real difference going to be between 1.0 and 2.0?
Yeah, I can answer that. So the pictures are the same. The difference is I'm a lot better at using computer aids in drawing. So you'll find the lines are straighter, the colors are a little brighter, the pictures are the same. So it's a classier picture. I'm very proud of that because, when you're drawing by hand, everything shakes. So the pictures are a little crisper, but the real difference is twofold. One major difference was I taught a GI physiology course between version 1 and 2. And I don't mean this rudely, but wow, you guys are terrible at GI physiology. So I realized I'd made assumptions about what everyone knew, which were wrong. So there's a real beefing up of GI physiology. The second was, I just didn't like the way I did neuro. I had to get something done. There was nothing wrong with it. I did cases that were neurology resident level. This is not who we are. We are medical students. Not to say that everyone can't benefit from it, but a medical student, you assume you know nothing. And so what I did was I changed neuro and I changed out the cases at the beginning to be much better neuro for medical students, because neurology is different from every other system. And this is the difference. In every other system, find the chief complaint, do a differential diagnosis. In neuro, it's find the chief complaint, where are you anatomically in the system? Do your differential. So you can't do good neurology if you don't have a picture of neuroanatomy in your head. And I got to tell you, I had a very discouraging week. I'm teaching at this medical school. And I got invited to this meeting in which they were talking about, it's a traditional school, so, subjects first year, clinical second year. And they were talking about how are we taking our neuroanatomy from first year and translating it into our neurology course second year. And it was me and 3 PhDs. And when I said, you're over teaching neuroanatomy, I just basically got blown out of the water. They just said, sorry, thanks for your opinion. We're not doing that. And I didn't like it because I just know it's wrong. And I said this, you should not do any neuroanatomy in neurology that isn't the physical exam or imaging. That's the only way you should see neuroanatomy. And basically they said, yeah, next. I just got blown up. So here's what I'm telling the students. And, you can appreciate I'm terrible at neuroanatomy because I was taught the way everyone's taught. I learned so much neuroanatomy, I had to memorize it, which means I never understood it and it all faded away in a month. So I'm terrible at it. And what I've been forcing myself to do, and again, it's one of my many projects that never ends, I'm actually writing a book on the physical exam teaches pathophysiology.
A new book.
Oh, well, I'm full of all these bright ideas that never get finished apparently I can't get 2.0 out. But yes, when you're doing a physical exam, ask yourself, why is that true? We keep coming back to congestive heart failure. Everybody loves a pump. But ask yourself this question. When we talk about chronic heart disease, we always talk about homeostasis. That's your sympathetic neurohormonal stimulation. And then it goes to adaptation. which for the heart is hypertrophy. And then you go into failure. So if I said to you, all I'm giving you is your physical exam, what in your physical exam would show hypertrophy? Isn't that great? Physical exam teaches pathophys. Okay, because when you get hypertrophy, your heart, as it starts to fail, gets large. And what that means is your apical impulse moves from sort of the middle of your chest, it moves laterally. So every medical student I know can tell me, lateral movement of the apical impulse. Yeah, everyone can do it. But when you say, why does that let you think it's failure? How many can walk that stepwise through to say, because I've gone through my adaptation following homeostasis, and that has actually given me a bigger heart, and so it's moved. That's why I need that physical sign. I've got hypertrophy and a larger heart. So in neuroanatomy, you've got to be able to say, why am I testing this? So let's just say you took a little pinprick and pricked the big toe. Okay, so now we're doing the spinal thalamic tracts. And it works. Good pinprick sensation. In your mind, can you draw the nerve, cross over the spine, up to the thalamus, up to the cortex, and imagine, well, here. Those are the common disease areas, and that's what I just ruled out. Because I've got to promise you, I'm terrible at it. So I've got to write the book first to teach myself, and then everyone should say, when you do a reflex, what have you actually measured? Go draw one. Great. What did you just prove? So, you can get snippets of it in places, but again, we're back to this terrible divide between the PhD understanding of the neuroanatomy and the neurologist that says to herself, I've tested these pathways because these are the diseases I've ruled out.
If students have already purchased 1.0, which a few have, and like, oh no, we have 2.0 coming out. It's a really good textbook.
The pictures are all the same.
Yeah.
And this sounds funny to say, but you're really doing the book for two things that are really different in it. The first is the pictures, right? I draw those pictures not to illustrate. That's my brain. So when I hear you say, pick something, pneumonia, what picture am I waiting you to tell me? I'm waiting for you to tell me, show me the chest x-ray. Is it alveolar or interstitial? That's what I'm waiting to hear. And I'm waiting for it. I see it in my mind's eye. There's my little picture of the chest, and I'm going to draw consolidation or reticular nodular because that's going to be alveolar or interstitial. So when I draw those pictures, that's my brain. You have to draw those pictures. I'm not doing it as art.
We had a viewer ask, at what point in med school should we start using your textbook? Is it from day one?
Absolutely from day one, yeah. Because you're not going to be taught full-time by MDs. We were overwhelmingly MD taught, with PhDs coming in as subject experts because they had more time and they were very good. So, for example, my histology was PhDs. But almost everything else, physiology, all that stuff was heavily MD. You've got to finish each unit that you do, and then you go to the book and say, what in the book covers this? Right? So let's just say you're in a classic school like I'm teaching in now, and you do heart anatomy. Right? So I'm in second year, I'm mostly a second year teacher, and I'm in cardiopulmonary. Right. If you go look at the anatomy, I can't use it because it's not done the way we think about heart in cardiology. Everything is always the echo, right? So if you don't see the heart as short axis, long axis echo, then we don't match mental pictures. So, of course, you have to pass what I'm now learning to call your local exams. I get that. That's, they're the ones that are issuing your degree. You've got to pass their exams. But remember, you do want to pass your national exams and be a good doctor. So do your heart anatomy, then go to the book, pull up the structure function chapter and say, and this is how I've got to think about it clinically.
Speaking of books, we had someone ask how you would rate Pathoma.
Once we realized that the internet existed, there were a few people that realized I can reach a larger audience. And one of them was this very able pathologist up in Chicago. And as he tells the story, he was down in the basement by the furnace, and he was astonished that everyone wanted to see his notes. So, of course, he did that. And he basically took Robbins and did a really nice job doing Robbins. Almost all those original people eventually ran out of energy and sold out. So, the guy for Pathoma, he ended up working with Robbins. Well, that's great if you're a first-year pathology resident. The trouble with Pathoma is I don't think Robbins is right for a medical student. Ask yourself, think of all the things I say. Testing teaches pathophys. Do you have a mental picture? Go take a look at Robbins and see how many of those are there. The answer is none. It's for a first-year pathology resident. Do you really think you should know 12 testicular tumors? No, that will harm you because you'll actually think you should know that. How many ovarian neoplasms do you think you need? I teach 4. There must be 44. Don't do that. The two things for example, what do we like in my book? The first is those pictures. Those aren't illustrations. Those are my brain. And my brain isn't special. All doctors see it this way. I'm just showing you how medicine teaches itself. The second is the best part of the book, and no one ever even knows it's there, is Appendix A, because it lists all the 50 to 60 chief complaints you need finishing your basic science as a clerkship. So, when I say shortness of breath, chest pain, abdominal pain, do you have a differential and an approach to it? So those haven't changed between the old book and the new book. Pathoma, if you've got a traditional pathology course and your local exams are traditional pathology, Pathoma's fine. But it's not pathophysiology.
You say that this is the way doctors think. And with any good brand landing page, you will get a testimonial section. And the one thing that's just delighting me in helping build your social media channel is that people are leaving testimonials publicly. We don't have to go searching for them. We don't have to make them up. We have practicing physicians that are writing in saying, yes, you've literally articulated the very thing that I'm doing in my own practice. You have students that are like, I bought the textbook, or I've listened to your lectures. I'm now in your system and I'm watching your videos. It makes sense. It is dramatically changing my life.
Well, let me just stop you there with my favorite testimony. So, we teach around the world. And because of the internet, I've taught Indian students remotely. And I mean this categorically. They are my favorite students. They've been so highly selected. They're so obedient. And they've all memorized to perfection. And when I say, let's talk about why you learned that, they go, OMG, they just can't believe it. And they're very obedient. So unlike the rest of you slackers that go, I'm going to learn that picture someday. No, they actually go learn it that night. And so when I pick them up the next day or so, I say, how did it go? And out of a group, I do 30, 40 at a time. Out of that group, there will always be someone, because these are often interns and residents that want to come and study in America, so they have to pass the STEP exam. And the greatest testimony you'll ever hear is, we were standing at rounds in front of a patient, the 5 to 10 of us, and our preceptor asked the question, and I was the only one in the group that knew the answer. And you just go, we are clinical, and this is medicine, and it works, and it makes you feel so nice learning it. And why wouldn't you just do this? Just stop memorizing, learn the pictures.
So then maybe you can help us respond to one of the few haters that we've found on your channel. We've gotten a couple of these comments by people who are really thrown off by the idea that you are promoting your textbook. He goes, lost me already. I'm like,
yeah, right, because they think I'm hustling my book.
Yeah. How would you respond?
Let me be clear. I am. I mean, clearly we make a modest profit. And so I was thinking about this in my walk today because I had read that comment myself. And I sort of had 3 thoughts. Here they are. The first is, no one goes into teaching to make money. Like, I'm a full-time professor of pathology at a national medical school. I make a third of what I made in a small-town practice. No one does this for the money. So if you're going to accuse me of commercial interest, I'm just going to laugh. The second is, you do need the book, because the book is my mind. When I say the one thing that I've really learned at my new school is students don't understand the importance of having a precise, tight pathophys. So when I say hereditary spherocytosis, can you just punch it out? What's the word for the pathophys of sickle cell? If you don't say microvascular occlusion, my friend, you're floundering. Well, that's what the book says. I've repeated it 10,000 times. Why don't you just go read the book and then I don't have to repeat it 10,001? So the book is my mind. It lets you see that. So the internet was coming out about the last 15 years of my practice. And so we could really access current information. And, in the last 10 years of my practice, I bought one book. That's it, only one book. And that book happened to be a fantastic pathologist down in Boston who was really a national expert in sarcomas. And all my sarcomas, I referred to him. And I loved his brain. It was just so good. And I was never going to be a specialist in sarcomas, so there was no rivalry. And I bought the book because I wanted to study his mind. I thought he was that good a pathologist. I wanted to read how he wrote and see if I could mind meld and understand how he worked, because he was a wonderful pathologist. That was the last book I bought. So, when you have a book, there's something different about a PDF and a book. They go to different parts of the brain alley. I don't think it's one or the other. The PDF, for sure, portable. I mean, who could argue the portability? There's something about a book that you can write in. There's something about a book, it's fast. You can go back and forth. I don't see it as one or the other. So when you have the book, I mean, I have one right here. This is my working office, right? Yep, right beside me. I will open it 4 times an hour. I'm writing multiple choice questions. I will open that 4 times an hour. It's just so much faster than going through a PDF. I hold it in my lap. It's right there. It has better resolution. So it's not either or. So yes, you should buy the book. And yes, we do make, 10 or 20 bucks a book. Thank you very much. Now, what are tea and Rachel? A seventh thought is this. You will never separate medicine and money. Medicine is an essential human relationship. It does affect lives. It does affect how people live their lives. No one can deny this deeply important function that it does. We all want the best for everybody. I get that. However, a hospital has to make at least 3% profit to be able to keep itself going, because buildings age, gardens have to be kept, you have to get new machinery. So if your hospital isn't making at least 3%, it's dying. So it's the old expression, no money, no mission. And so here's my advice. Stop trying. Money is an important part of medicine. You can don't ever try to separate it, but don't ever let money drive medicine. Medicine will always be the relationship of a patient and her doctor.
I completely agree. And I think it also leaves us room for things like scholarships, for things like third world medicine. It's not saying it has to be all of one or nothing of the other. But unless you make money over here, you can't possibly offer these services over here.
Oh, no question. No money, no mission. The third thing I'll point out is what social media has taught us. You know how it's all free? And what we learned was it wasn't free. It turned out we were the commodity. And what you've seen is, it's a terrible word, but I really do like it. So please forgive the vulgarity. It's called the enshittification of everything. And it refers to the fact that, when Google first came out, it was a wonder. You would put your word in and you would think, and you'd get this list, most likely, and it was fantastic. And then did you notice they started sponsoring things? So all of a sudden you had to go through 2 or 3 things to get there. And then you notice it started following your taste. So then it started prompting you, hey, saw you bought a wheelbarrow. We got a bunch of wheelbarrows. Dude, I don't need 2. They've never made a suggestion yet that was useful to me. But it bothered me that I knew they were studying me, not to make my life better, but to sell stuff. Okay, we're not selling the book that way. The fourth thing is, and then it started trying to influence our choices. Then it started, if you go to Google now, I don't use it because it's been so driven by squeezing the last dollar out of everything that it's ruined the experience. And you're left with this feeling, isn't anyone proud of their product anymore? Aren't you willing to give up the last dollar so that you're proud of what you make? And I go to the Googles and all the other ones, and the answer is no, we just want the last dollar. Well, trust me, that's not us. So if you have to pay for something, you and I understand our relationship. If this book is a good value, then you can buy it. If this book is not, don't. But I'm not going to make you my object of profit. So I kind of started paying for things on the internet now because I want that clean relationship.
I think that makes really good sense. And, once they have, if they do decide that the textbook is of value, I think what they're going to find is it will shape how they are consuming and organizing the information that they're already learning in medicine. But then the point that you've made in the past, and I think it's something to reiterate here, is that they have to go and test themselves. And so we have a lot of great existing resources. You have these sort of live onlines that were pre-recorded. We're going to have all of that we have it all in the current community. It's all going to be in the new community as well. But you're going to be actually going live coming up in the new community.
Oh, I do it all the time at my medical school. I'm going live with my students. And here's what's such a funny comparison for me. So there's roughly 150 students, 180 in the class that I'm doing. Only 15 will show up for me live. But I bet when we go out to the world, people will be so happy to show up live. I'm really looking forward to the comparison of this. Only a small number of my students actually understand the power of talking this stuff through versus what we're going to see in our community. So I'm really excited. Yeah. So we're going to do two different things live. These are sort of, I'm happy to do anything, but I've had good experience with this. The first is open mic. Bring anything you want. Bring a UWorld multiple choice question. An hour later, we'll be coming up for air. The second is something will happen when I'm teaching and I'll sort of go, wow, why would you think that? So for example, I got pinged by a student this weekend and she said, does the dilation of the aorta cause the cystic medial degeneration in the wall? I went, well, it's the opposite. The wall degenerates, weakens, and it dilates. And I went, why would you think that, And so I didn't answer. I simply said, free to talk. And we must have had 30, 40 minutes of she had never walked through a pathophysiologic sequence. Start with your ascending aorta. Tell me how its bioengineering works. Walk me through its elastic layers. What causes that to degenerate? When it degenerates, what does it look like? So now the wall weakens. Tell me what happens. Does an aneurysm in and of itself bad? No. But it gives you that goo in the middle, so you get a little tear, and it races down that tear. So aneurysms of the ascending aorta dissect. Yeah, aneurysms of the abdominal aorta, they blow like a tire. So it was the first time someone had walked her through the timeline of a disease and made pathophysiology explain everything. Well, that was one student. So that's a case I would bring to live mic and say, hey, let's walk through what cystic medial degeneration go.
Well, you can see that Dr. Tisdall obviously has a team working with him, myself included. And I can't even tell you how driven we are to get this community and these lives set up as soon as possible. It turns out there's we have to create an app and everything, but we are gunning for it. We're trying to get it to you guys as quickly as possible. And in fact, I think there's a little bit of internal competition about who in our team is pushing the hardest in terms of getting this all forward. So we're doing absolutely everything we can to get to this to you as soon as possible.
It sounds like excuses to me, but
it's a lot of excuses. Before we end this podcast, Dr. Tisdall, maybe you can just give us a little glimmer of what sort of topics you're going to be teaching just like a general framework of the kinds of topics that you want to talk about in your live lectures. Just give us some throw out some examples.
So we're gonna start with two themes based on my experience. The first theme is open mic. Bring a problem, and we'll just talk about that problem. You can't believe you bring the simplest thing. Most of the time, it shows something wrong in your brain and the way you're learning it. And so we have to go all the way back and use this as an example of how to learn medicine.
Now, are you talking about like a question bank question, or what sorts of questions?
Anything. Students can bring anything that they want to talk about, and I will not only teach the subject, but I'll use it as an example of how do you use medicine to teach yourself to learn medicine. Right? So here was someone that thought aneurysms cause cystic medial degeneration, and now all of a sudden she's learning the picture of chronic progressive disease. The second thing I'm going to do is it's very hard, harder than I would have guessed, to go from a chief complaint to a differential, rule in, rule out. It turns out that's not easy. And part of what you have to be able to do is say, when I give you a word, give me the picture that goes with it. So, for example, the group I'm working with now, we're doing cardiac, and this is now the third straight session in which I've said, what are the 5 presenting symptoms of heart disease? And as they march through their cardiac system, I'm bringing it back to that. So we've done arrhythmias, palpitations. We've done syncope. We've done chest pain. But chest pain, they happen to get aorta, as you can tell from my conversation. So when we did the differential chest pain, last week I worked on aneurysms. But now they've done coronary artery disease. So I'm going to do the same differential. They're still going to have to do the differential of chest pain. Now we're going to do angina. So when I say, angina has its own differential, right? Well, I promise you there's going to be a lot of groping and searching and heretofores and notwithstandings. And students have an impossible, you have to do it about 20 times in my experience to say angina is stable angina, or they always want to say unstable angina. It just feels so right. The answer is no, acute coronary syndrome. And then we have to walk through the clinical pathologic correlation of acute coronary syndrome. And believe it or not, that's not well taught in most courses and books. So today, I'm going to make them go differential of palpitations, differential of syncope. Hopefully that goes well so I don't have to spend 25 minutes on it. We'll do chest pain. And then I'm going to say, good, today's emphasis will be on angina. And then we're going to walk through angina. So that's what it's going to feel like live is you either the student can start it and we'll start, how do you think about? Or I will start it saying, you've got to be able to do this.
Every time we have a new asset, an update on what's coming out, or any information that we want to relay with you, check the description because I'm going to be updating those links when the new textbook is out. I'm going to update those links. I'm going to make sure that you guys are in the know so that you can be the first to hop on any of these resources that we're putting out. As well, clearly you can see we read your comments. We go through that in the comments. We talk about them. Oh,
Don't
we
you
love
enjoy
starting.
I mean, it's nice to get praise, but a good snark is special.
So special. And so we talk about which ones we want to talk about in each of these podcasts. So make sure you're posting your questions and I will do my best to let you know if we've answered it in a future video. Other than that, if you really enjoyed this conversation, we have a whole playlist of Dr. Tisdall Unfiltered, and I'm going to link that here so you guys can click on that. Otherwise, we will see you next week, Dr. Tisdall.
Yes, ma'am.